Thank you so much. And we go on with the big question, autologous CAR T versus allogenic. The first speaker is George from Northwestern University. He's a medical oncologist.
Good morning. Thank you very much for inviting me to this really great meeting. It's super interesting. So just to review a little, how do I advance the slide? I just want to review a little bit what happens with the, shoot.
Just use the down arrow.
It's a down arrow on this device. There's a, oh, this one, sorry, okay. I have like a couple of down arrows on the keyboard, okay. I'm talking about autologous CAR T compared to allogenic CAR T. And these are my disclosures. And let's review a little bit the time. One way to think about it is to review the timeline for CAR T. In a study, patients need to be screened. You have to do a bunch of screening tests, evaluate them, the risk of including maybe pulmonary function tests or 24-hour urine collection, CT scans, depending on what the disease is. But it takes a while to do all of the screening tests. And at some point, you need to taper and wash out the immunosuppression to perform apheresis if we're using autologous CAR T. And then there's this, in yellow, there's this manufacture period of the autologous CAR T. And this can take anywhere from maybe as short as 2 weeks to maybe 5 weeks, 6 weeks to complete. And during that time, patients need to go back on immune suppression therapy. Again, before the lymphodepleting chemotherapy, patients have taper of their immunosuppression typically in order to make way for the incoming CAR T. And infusion of the CD19-directed CAR T. And then there's this expected period of neutropenia, cytopenia. There's a risk of CRS a little bit later, and a risk of ICANS, and the risk of sort of a delayed hemophagocytic lymphohistiocytosis, which is sort of a later form of inflammation that can occur, especially if there was a lot of CRS or ICANS. So the the problem is that it takes some time to generate the autologous CAR T. However, let's say the pros. The manufacturing systems are really well developed, safe, and reproducible. So the autologous CAR T are primarily used for lymphoma and for multiple myeloma, and the industry partners have really worked out the kinks in terms of growing the CAR Ts and generating them. So this is a reliable method that works in the vast majority of patients. And it's a FDA-approved product right now, the CD19 and the BCMA, although others are coming along. And it is a patient-specific therapy, and this is often very appealing to patients that they're providing their own sort of vehicle of drug to treat their disease. And in some of the manufacturing improvements include decreasing the manufacturing time, maybe decreasing it to as little as 2 weeks from vein to vein experience. But that's still not uniformly done. But that's a goal that I think is achievable, maybe with less ex vivo expansion. And with the autologous CAR T, the cells are less immunogenic. I mean, the CAR T is immunogenic, but they're less immunogenic than an allogenic cell. And there's potentially, especially if we're using CRISPR technology, less risk of off-target gene mutations, because you're just using the lentiviral vector to transduce the autologous CAR T. And because you're using autologous T cells, likely you have to use a lower dose of lymphodepleting chemotherapy. This is a concern for many patients with autoimmune disease or women who want to retain fertility, of using the least amount of chemotherapy possible to allow the CAR T to do its work of depleting the B cell. And with autologous CAR T using fludarabine cyclophosphamide, we wind up not having to use very high doses of fludarabine cyclophosphamide. Allogenic will likely need a stronger dose of lymphodepleting chemotherapy for the cells to do their work in vivo. And the autologous cells expand in vivo and persist longer to achieve this deeper cellular lymph node depletion than allogeneic. The allogeneic CAR T are likely to be shorter-lived. This is evident also in the lymphoma trials, where the allogeneic CAR T are not really being focused in lymphoma trials anymore. They seem to be less active, less expansion in vivo, and less persistence, which makes the autologous CAR T favorable for the lymphoma trials. And with autologous CAR T, there's no risk of really graft versus host disease. Even though the GVHD risk is low with the allogeneic, it's a potential theoretical risk. And because of the CAR, there's also a likely lower risk of infections if we don't need to use as much lymphodepleting chemotherapy dose. And because you're targeting the CD19 with autologous cells, and they're not being rejected by the host immune system, there's likely a deeper depletion of the using autologous CAR T. And autologous CAR T might be more expensive than allogeneic off the shelf, but in balancing it, it might be worth that to have the longer disease control with the autologous CAR T. So I think autologous CAR T wins. Okay, just to end it up.